Okay. I am going to start. I don't know if they're hearing me or not, right? Am I being heard?
Yes, we are here.
Okay, okay. So first of all, thank you so much to the organizers of this webinar for the opportunity to talk about psychoanalytic work with babies and parents and think about it and its preventive aspects with our colleagues here in the webinar and all over the world, especially during these challenging times. And to start our section on working psychoanalytically with babies and their parents, I will start with a short clinical story. A mother calls a clinician in desperation because her 9-month-old baby boy is not sleeping and the parents are at their wits' end from lack of sleep. So they come to the first appointment with the baby. The first thing the clinician observes as they walk in is a robust baby that is calm in the mother's arm, inspecting the room with a serious face. The mother starts to talk after she places the baby on the mat close to her with some toys, and she starts telling how exhausted and helpless they feel with the baby's nightly crying. They put him to sleep every night with the same consistent routine, but the crying starts as soon as the mother tries to leave the room. The baby can cry for a very long time, very hard to the point of throwing up. And this repeats itself every night, several times during the night. The father had tried to relieve the mother, but the baby demands only the mother, so she keeps coming back. While the parents are talking about this during the session with very strong feelings, the clinician observes the baby who is on the floor, handing the mother the toys one after one and asking for the toys back, ignoring both the father and clinician. The clinician addresses the baby, saying that it is as if he wants mommy all to himself and doesn't like his mommy talking to a stranger. At that moment, the baby then bursts into a big cry and demands the mother's lap. The clinician experiences feeling superfluous, an intruder like the father. She then says to the parents that there is a repetition in the session of what happens during the night, the baby rejecting anyone but the mother. She asks the mother about her anxiety of letting the baby cry, about leaving the room at night. The mother replies by sharing her feelings that she cannot bear or explain, of a great fear that grabs her when she attempts to leave her baby alone at night. She has been having repetitive nightmares of waking up and going to look for her baby and not finding him, looking for him among the covers desperately. The father describes his frustration with the mother and the baby and the strain this is placing on their relationship as a couple. While the couple is talking, the baby stops crying and pays close attention, moving his eyes between parents and clinician. This time, when the clinician speaks to the baby, he says, "Oh, you are so curious now. You want to understand things as well about your feelings and your parents' feelings." The baby smiles shyly to the clinician, and the parents are surprised and quite delighted. In the following session, the mother brings a dream. In the dream, the family is all together. A man is knocking at the door, asking to come in, and she feels great fear and excitement. She wants to open the door, but no, it is very dangerous. What unravels during this second session is the mother speaking of her father who died when she was a young girl. She knew that the man in the dream was her father. In the session, she recalls his death. He was sick at home. Then one morning, she went to her parents' bedroom and she discovered he was gone, the bed still unmade. Her father had been taken to the hospital where he died. She recalls while crying how she searched for him among the sheets, trying to find him. It's an image she cannot forget. This remembering of things past, her grief and unresolved loss, enables the mother to understand what she has been projecting onto her son and onto the night, along with some of her unresolved Oedipal issues that brought her to reject her husband. It enables her to process her feelings of loss, to understand her baby and his needs, and slowly to release her son at night so that he can eventually find inside himself a stable internal object to calm down with, thus finding his capacity to fall asleep on his own. She is also able to accept the father's help. He is now capable to assert himself and establish more of a father-son bond, thus allowing the third to enter the relationship, which promotes the son's growth. The couple's relationship improves as well. This all takes place within a few sessions, by which time the baby is sleeping through the night, and then the mother requests a referral to start her own individual therapy. We have started with this fictitious scenario, one that is common in our baby practices, to show how babies clinicians work within the solid psychoanalytically informed parent-infant psychotherapy modality. It is a well-established modality based on psychoanalytic theory and technique since Freud, who many of us know was the first one to observe a baby with a psychoanalytic mind. It aims to alleviate baby's pain and promote and improve parent-child relationship. Repairing relationships and addressing infants' distress is what makes this work highly preventive, especially now when parents and children are experiencing acute anxieties regarding confinement, fear of death, and uncertainty. As their traumatic systems are triggered and their capacity to think compromised, it is critical to find ways to help parents resume their capacity to think, which is a strong preventive antidote. It is what allows infants to resume their developmental course and continue building their sense of self. This is accomplished by lifting toxic parental projection, which is the focus of the technique we are describing. Newborns experience helplessness and primitive anxieties in the face of total dependency along the inevitable environmental failures. When these anxieties exceed the infant's coping capacity, they develop symptoms that alarm the parents. So distressed babies in their first year bring their parents to the clinician's office with symptoms such as problems with bonding, feeding and weaning issues, excessive inconsolable crying, sleeping difficulties, failure to thrive, developmental concerns, and more. And in the second year, there are other issues such as toilet training, behavioral problems, tantrums, and so on. An important aspect of the technique at the disposal of our PIP clinician, as we saw in the case presented, is her frame of mind that is capable of carefully observing babies while thinking psychoanalytically with the parents. This, along the capacity to develop free-floating attention, creates a receptive mind that is capable of absorbing and containing emotional experiences. The close, attentive observation of the baby and the parent in the room is essential for understanding the internal experience of both the adult and the infant, and for being aware of movements of transferences and countertransferences, of projections and introjections among all participants. We saw it in the example above, the clinician using her countertransferential experience with the baby, feeling ignored and excluded like the father, to address conflictual areas in the parents and the baby. Also, the clinician needs to balance the over-identification with either the parent or the baby which allows her to know when to address the parent and when to address the baby. The clinician takes in and thinks about what the parents are saying and what their baby is communicating, so that an integrative process that yields meaning can start to develop among them all. The containing mind of the clinician in a state of primary concern that pays attention to unconscious processes in all enables parents to start thinking about their baby in a different way. They can then adapt to their baby's needs and contain anxieties. This containing attitude guides the clinician to the heart of the matter and offers the parents the mental support they need to support their baby. And now, Christine.
Thank you, Talia, very much. Now, before handing over to Christine, I would like to say something that really was part of the introduction. Very briefly, I want to explain that Christine and Talia work together. They have a shared clinical experience in the faculty of the Columbia Psychoanalytic Center for Training and Research, where they direct the Parent-Infant Psychotherapy Training Program. Well, Christine, it's your turn now, please.
As Talia said, observing nonverbal and bodily communication of emotions is essential when working with babies and parents. The very attentive psychoanalyst, looking carefully at the infant and taking care of the mother's vulnerability, serves at first as a narcissistic support. Her mirroring the mother's and baby reaction and giving meaning to the parents' conflicted affect give them the opportunity to use words about their confused feelings. When not massively negative in case of narcissistic disorder, the transference from the parents is mostly positive, putting the analyst in a kind of grandparent position. This helps to explore the parental projections facing a newborn that represents a new generation that puts the parents in a new role, arousing Oedipal issues and the loss of their own position as children of their parents. For the analyst, this is about protecting the narcissism of the parents by not entering into an educational role, at working for the support of the psychic apparatus of the child, whatever the symptoms, and at creating a thinking process in the parents. The baby participates in an extremely lively and active way in the exchanges with the analyst. He is permeable to changes in his environment, and his psychic organization immediately benefits from the appeasement of maternal anxieties. It is sometimes difficult for the analyst to remain neutral in the face of a charming baby which shows all his smiling vivacity to discover the world and himself. The analyst's role is as much to uncover the parent's unconscious movements as it is to serve as a filter and container for the child. When receiving very young children with their parents, the psychoanalyst offers her capacity for representation or imagination and symbolic deployments to the couple formed by the baby and the mother, supported by the father. The child is in the premises of object relationship. The parents are caught up in the intensity of their projective identification and their own regression. The integration of part of the self, personalization, the symbolic use of objects are easy processes when the relationship with babies and mother is good enough. Break in these processes fails the ability to establish an object relationship. The sense of self, the sense of being alive, subjectivation and autoeroticism are in constant connection with the maternal creative capacity. The intense drive exchange between mother and baby combine construction of phantasmatic activity and construction of the subject-object of desire. All this allows in the child for the capacity of representation. Current theories on the beginning of psychic life allow us to imagine the importance of the relationship with the environment on the representational capacities in young children. What we know about the psychic life in infants regarding the theory you're using, Sigmund Freud, Anna Freud, the Kleinian, beyond, we all have a representation of psychic life in infant. The modalities of the object relation and the real and phantasmatic bonding with the mother and with her own symbolic capacity form an essential basis of the work on the analyst in the presence of a baby with his parents. Creating a transitional space in treatment, a space for thinking, for play and illusion between mother and child is a major goal for the psychoanalyst. The deployment of activities of representing, displacement, associations offer the child the opportunity to have completely new experiences, and the parents the opportunity to display their creativity. The analyst's capacity for reverie can favor that of the mother. The transitional space opens up between mother and child. The condition is that the mother also participates in this magic. It is an aesthetic and sensory experience. It's an opportunity to pass on family traditions to the child by remembering her own childhood experiences. Parents blocked in their associative possibilities, mother depressed or persecuted by their child, adults stunned by grief and traumatic experiences of the past are unable to play this sharing. The analyst's art is to deal with parents' conflict and at the same time reconnect with an associative process that repairs their creative and playful possibilities. The value of play can immediately be therapeutic for the child, who then has a completely new experience with the object. In critical situations of psychosis, melancholic depression, violent projective system associated with abuse, therapeutic intervention must be of different order. Even when the parental pathology is not so heavy, sometimes the child is already caught up in registers of relationship disorders, avoidance, or autistic defenses, which require treating the baby for himself. But when the analyst can play his role with the mother, he is rushed to help her recreate her own maternal functioning when the child is already exhausted in vain at this task. A young child cannot survive in good mental health without a living and present object, but he is very active in the process of interaction and change. Babies almost have a knack for connecting and calling their environment to stay in touch with them. Those who are not so fortunate, premature, sick, or disabled babies demand even more care and adjustment. Those who have the energy deploy complex strategies to stay in a living relationship with others, efforts that we observe in face of depressed mothers. The baby has an active role in the encounter with the object. He needs to prove that he is able to transform the object. The main thing is to achieve a sharing of affect. When the analyst manifests this attentive availability and promotes maternal reverie, the back and forth between attention given to the baby and to the mother finds a rhythm. This is when the mother and baby can be in tune. Many mothers need help to endure being unable to understand their baby that they want to keep alive and protect. Waiting for the child's signals without being intrusive or inadequate requires a lot of confidence and flexibility. by opening up the possibility of stating one's own memory, family history, conception of the baby. As analysts, we introduce capacity for representation and symbolization. The quality of the harmony between mother and child offers the baby the illusion that its drive satisfaction is its own creation, the founding illusion of self-feeling and of narcissistic regulation. The lack of emotional tuning, of bodily adjustment, takes away the child's hope of creating the world. A mother overwhelmed with anxiety, depressed emptiness, or paranoid projections cannot offer her child the mirror of his own experiences. The baby risks incorporating that is the source of the bad, full of dissatisfaction and chaos. The danger is that of narcissistic attack, which leave its mark throughout life, reducing the ability to feel alive. It is seen in babies who emerge from the relationship by avoiding the maternal figure and sometimes close in an autistic capsule or fold up in compulsive self-calming processes. Metaphor is the royal channel of communication between the analyst, the child, and his parents. To address the child in front of his mother, to encourage associative play among parents, the analyst plays with image, ideas, new representation. It is a very process of constituting representation that is thus transmitted. The analyst thinking, making associations, create links, help for the identification with the therapist in parents who themselves can start making associations. The as if of the analyst proposal has meanings that open up for the formation of new bonds. The ambiguity of the analyst formulations allows sharing, differentiation, freedom of association. Listening favorably to a mother makes her creative and empathetic with her baby. An analytic process is underway. The experience that a small child can have of entering into different relationships with the world in the analyst office can in itself be a source of change. Changes in the child's psychic functioning with then favor a better encounter with a less guilty and more adequate parents as the child learns to relate. The surprise effect is a mutant moment of those analyses. It has particular value in joint parent-baby treatment when the child discovers the mother being surprised. The associative quality, the revelation of an unconscious movement, the reception of an unknown part of oneself makes the surprise an event both internal and intersubjective. The psychoanalyst maintains a framework that gives security and rigor. She offers attention, mobilizes the transferential relationship, so the ability to surprise oneself can be revealed. It is the time of emergence of fantasies and the sharing of discovery. If there is one place when the psychoanalyst has the essential function of creating a transitional area, it is in joint parent-baby therapies. Revealing the parent's unconscious content, introducing a third function between mother and child, presenting the baby with opportunities for new experiences, revitalizing the emotional bond. All this is only possible if the potential space is deployed. The family Talia presented has gone through a typical evolution of a session when the baby reacts as a wonderful partner in a session. At first, the 9-month-old boy started to scream when listening to the stranger's voice. Then, a few minutes later, smiled to the same stranger, talking to him nicely, allowing for the analyst to make links that led to a process of associations and dreaming in the mother, and opening for a new field of identification to the baby and to detoxify the maternal projections. In the critical moments that we are all sharing now, in the present moment, during the virus epidemic. There are many families in distress that reveal the impact of past traumatic experiences in parental capacities. We are seeing now many dyads in crisis, and we have to be ready for a surge in depression in children. Psychoanalytic intervention are and will be essential for prevention and treatment of babies in their development and for young children. Like in child analysis, analytic treatment with babies have a very positive effect on the whole family. They help to prevent pathological interference with the child's development, as they have a powerful and long-term consequence on the parent's mental health and on the psychosomatic balance on the whole family. Thank you.
Thank you, Talia. Thank you, Christine, for your extremely clear and vivid description of how you observe and how you intervene in parent-infant psychotherapy modality based on psychoanalytic theory and technique. Now I hand over to our next panelist, but before I want to remind you that you might send along the whole course of the webinar your questions that would be treated on the second part of this webinar. Look at the right side of your screen. You will find a box called questions. Open that pane and there you might write and send it from now on. Remember, they will be answered in the second part. Now, I want to introduce briefly to our second panelist, Regine Pratt. Regine is psychologist and psychoanalyst, member of the Psychoanalytical Society of Paris, trainer in Esterbik Infant Observation Method, member of the Gerpen Group of Psychoanalytic Studies and Research for the Development of the Child and the Infant. She is interested in the premise of psychic life and the beginnings of symbolization and its hindrances. She has worked on making links between various fields, such as developmental psychology, prehistory, neuroscience, embryology, and to identify common points in psychoanalytic clinical practice for babies, children, and adults. Well, Regine, please, it's your turn.
Okay. Hello, everybody, and thank you to welcome me. I apologize for my English. I'll try to be as understandable as possible. So I'm going to start right away with what is the heart of what I'm trying to say and what I think is most important in what I want to say. All my subject will be to consider the prenatal period as a period of great fragility, of fundamental change in the organization of the internal world of the parents, and to militate for psychic health, which, as Christine just said, which will avoid the installation of pathological modes of defense. So I propose that birth as a parent can be considered as a traumatic. This is an event that will lead to a change of identity and whose impact is particularly strong for a first birth, of course. It's 3 points. First point is a major identity crisis for the parents. It's what I call birth trauma for parents. First of all, I will give a brief example, very extreme, but really true. And that can help us to have a picture of the situation. So it's a baby of 3 months half, and the family is in a very big crisis. I don't tell the story, but after 3 appointments, the situation calmed down, and I ask the parents what happened to them, what overview we can have on the situation. I asked to the father, what is it like to go through all this experience? And look what he will answer to this question of becoming a father. He says, it's like taking a car in full force upside down on the highway. That's to say, it's an unexpected, but even more, a completely inconceivable frontal shock of an extreme violence which break into your life and cause irreversible damage. What's more, the image of the highway puts the focus on the speed and the fact that you can neither go out nor come back. It's like it is when you become parents. That's to say, it creates a violent, very violent situation and a situation of madness. As we know with Winnicott, of course, we know the normal madness, mother madness, and all this period is marked by a paradox. I will give some example of this paradox in the birth itself. The birth itself faces with paradox between life and death, living and not living things and human and so on. For instance, when we can have the first representation, the first pictures of a baby in the just after the birth, the parents, the mother can say, and these are examples from my clinic. I have not statistics, I have not made research on this topic, but the mother said that the first see of the baby was a whitish disarticulated doll, or a baby with an eggplant head, or a baby like a little cat, bloody cat, and so on. The fathers are in the same mood, and I remember a father who said that the experience is shock and perplexity when the midwife said after the birth of the baby, "Oh, it's a little doe." And his perplexity was that it could have been really a little doe. After witnessing the madness of childbirth, anything was possible, even the birth of a doe in this moment of strangeness and loss of connection with reality. So it's easy to see how delusional scenarios can be built on this experience and why delusional episodes, which in these circumstances we will call psychosis, puerperal psychosis, but they are 3 times more frequent in the population of recent mothers than in the general population. And the science fiction teams like Alien and others are clear pictures of the anxieties and of this traumatic experience. So the first level is the birth, and the second level is the encounter with the baby, like a traumatic experience that overwhelms the capacities of the psyche to cope with it, because it requires for the mother a fundamental and immediate reorganization of all her psychical functioning. The experience of parenthood faces for the first and only time in the life with the experience of a total dependence. That's to see the baby, the other, totally dependent for his survival to his parent in general, but of course, more particularly for his mother. If we take the traumatic definition of the vocabulary of psychoanalysis, the French Laplanche and Pontalis, they define trauma like this. And if you hear it thinking of the experience of parent, I think it's very clear. It's an event in the life of the subject, which is characterized by an afflux of excitement, which is excessive in relation to the subject's tolerance and to his ability to control and psychically elaborate these excitements. Facing this entirely new and singular situation implies a deep mutation of the parental psyche. Because of this transformation through experience, it will become radically different from what it was before. And Thérèse Benedek called this period of parenthood in 1949, like she described this period like a new phase of psychological development. In my opinion, birth trauma for the parent is the discovery of the baby's total dependency and is the common thread to underlying all the postpartum disorders. Then there is a second level of the experience in the relation with the baby. The relation with the baby will face the parents with something that I call squaring the circle, or an impossible mission that we know, impossible mission of being a parent. But why? Because in this process of parenthood, this involves the elaboration and transformation of the first feelings of terror and the acceptance of the baby absolute dependence. But the second aspect is the sign of this impossible mission of parenthood, because this acceptance of the dependency must be combined at the same moment, in the same time, with the understanding of the baby's autonomous possibilities. Because within this great dependency of the baby, he has, from the very beginning, areas where he can manage on his own. One cannot think that it could be one time when it's of an exclusive dependence first, and then an independency time. It's the both are present from the beginning, of course, in different proportions, and the evolution will be in more independency. But even a newborn baby is able alone to open and close his eyes and to suck his tongue to allow him to sleep, for instance. So becoming a parent presupposes being able to do at the same time one thing, perceiving and accepting the dependence of the baby, and the opposite, in the same time, perceiving and encouraging his independency. On the psychic level, I will not say a lot on this, but I think it's an important point that we can consider that on an intrapsychic level, I follow what Julia Kristeva defined like reliance, and she spoke about it in the last London Congress of the IPI in London. She says it's a specific economy of drive. And she speaks of an experience of motherhood as a fulgurance or an emergence, an immediate seizure that leads the mother to deploy a specific erotism, is what say Julia Kristeva. I will add the hypothesis of an intrapsychic traumatism in which the mother finds in a very, very important regression and deep identification with the baby, she comes back to an initial drive, which will constitute the foundation, the psychological foundation of the maternal ability, and is a regressive return to a primitive, what I call tactfulness of the drive. I don't know exactly how to translate in English. In French, I call it tact pulsion. It can work in English too. So what are the consequences? Why I find it's important to have this in mind as a traumatic? Because this has clinical consequences to consider birth as parent like a traumatic experience. First of all, because we must help the young parents to identify and name the sense of trauma and terror involved in the experience of confronting the baby's extreme dependence and the responsibility of the parents. This work of identification brings immediate relief and paves the way for an analysis of the defensive modalities against these emotions that have been experienced and repressed or erased. And this opened the field to the work of the reliance, what calls Julia Kristeva. And the sudden discovery of this crossing of the baby's dependence and the parental responsibility, complete responsibility, opens up the terror of a power of life and death. Impulse phobias reflect the shock of this discovery much more than unconscious aggressiveness towards the baby. Interpreting, I think that for psychoanalysts, it's very important to have the idea that interpreting unconscious movement, for instance, hatred, is largely inappropriate in this time. If we think back to the example of the father of Mary, who described parenthood as getting into a car upside down in the highway, it's clear that people who have just been in a car accident are not asked if they liked Bumper's car when they were small, or if they were playing accident with their brother, or if they were jealous of their older sister when she got her driving license, etc., etc. So we have just to have tact with them. On the other side, we will show this terror of dependency and responsibility. And in the same time, we have to share observation with the parents of the baby's spontaneous manifestation and to show to the parents the possibilities of his autonomous action. The perception of the baby abilities reduces the anxiety caused by the perception of his dependency. We will have to make a very important, I will not say a lot on this, maybe we will have a discussion, but we will have to make this confusion between a lot of things. For instance, the confusion between...
Regine, sorry for interrupting you, but time is running out.
Yes, okay, I just close on this confusion between effort and pain for the baby, for instance, and to try to have the idea that the baby is able to do things by his own. And just as conclusion, I can say that when we receive young parents, we must have the idea that they have the age of their child, 10 days baby, 10 days parent, and that the family birth clinic, similar to a post-traumatic clinic, that we have to help to avoid pathologic development, and that this support is a real public health issue. Thank you very much.
Thank you very much to you, Regine, for this description of parenthood from the viewpoint of a major identity crisis, what you call normal trauma. This has very, very important clinical implications. So I hope it will stimulate questions for our second section. Well, now it's the turn of our fourth and last panelist, Constanza Dualde. Before handing over to her, I tell you very briefly about some of her related scientific activities. Constanza is a psychologist and a psychoanalyst, member of the Argentinian Society of Psychoanalysis. She works as a clinician with parents and their infants, children, and adults. She works in different research projects related to infancy and early childhood at Buenos Aires University, where she also teaches as a graduate and postgraduate professor. Well, Constanza, it's over to you.
Okay, thank you very much for this opportunity to share with you some aspects of our work at the University of Buenos Aires. There I work with a team led by Clara Scheffman and including many colleagues, most of them child psychoanalysts. Our work is also helped by RIB grants of the IPA and the research training program of the IPA. As a team, we aim to build bridges between psychoanalytic ideas and observational-based research studies of the initial stages of life. Our approach has in mind three dimensions always: the intrapsychic of the adult or the mother, of the father and the child, the intersubjective one of the adult and the child in the mind of the other and in interaction, and the transsubjective, which includes the cultural, social, epochal milieu that is very, very important now in our time of pandemic and the context of isolation that have the families now. So this view allows to expand the field of knowledge of infancy and parent-infant relationship based on psychoanalytic thought. So what do we investigate regarding infants and their parents? I will describe here two central findings of our studies that illuminate parent-child healthy dynamics. Both are referred to affect regulation. First, infants of 6 months of old, and the second regarding infants or children of 4 or 5 years old. At the beginning, the infant is unable to regulate its emotional states on its own and is exposed to intense emotional turmoils and anxieties. So affective regulation can occur only in the context of a relationship with another human being, the mother, the principal caregivers, the parents. The mutual dyadic regulation, then, is the first form of affective regulation, and it's formed by an interplay between the reciprocal and synchronic positive matches where parent and child share positive affect, mismatches where they don't share the same affect, and mismatched repairs, particularly when negative affect or distress is displayed. This is a process, and it is critical for the achievement of the infant's homeostasis in the early stages of psychic development. By assuming internalizing this function, the infant reaches self-regulation. However, co-regulation of affects remains a lifelong characteristic of human beings and is essential throughout all childhood. In our research, we studied mother-infant affective regulation in 48 dyads, babies of 6 months old. There we observed in videotaped dyadic interactions in a laboratory setting using Tronick's ISEP assessment system, the relationship based on a second-by-second basis of observation. There we saw the mother and infant expression of affect, positive, neutral, or negative affect, infant affective self-regulation signs, such as oral self-comfort, and affective matches and mismatches. What did we find at this stage of life? We saw that mothers look at their babies the 90% time of their time together, seeing each other, while infants look at their mother only half of the time. Mothers show five more times positive affect than their infants. Their infants are mostly showing neutral affect. This means that only a short time of the interaction is a mutual positive affect. In fact, the most common situation there is the mothers showing positive affect and the infant in neutral affect. The infants of this age are interested in exploring what is going on in the environment beyond their mothers, something that I think Regine and Talia and Christine addressed. The moments of attention and inattentiveness in relation to mother are fluid. And usually mother, when I say mother, of course, I'm referring to the caretaking person doing this function. So usually mothers support these moments by looking at their infant and giving back positive affect. This means a huge work by the part of the adults regarding the infants. So the idealized paradigm of a synchronic mother-infant relationship of mutual gaze without failures should be reconsidered. The synchrony is better represented by a complex dance during the exchanges between the baby and the adult, where there are unique rhythms and styles, failures, mismatches, as we say, and misunderstandings. This is a good enough relationship. This depicts a good enough relationship. Adults' positive disposition that allows repair of negative affect or mismatches is essential. So, mothers, tolerance, and facilitation of infants' ambience exploration holding a positive affect display could be considered a maternal or adult's contribution to the building of the Winnicott's capacity to be alone in the presence of other in the construction of the self, or mother's role as a secure base towards her infant, like Bowlby described. In our work as researchers to explore the maternal subjective contribution, we included the concept of reflective functioning. This is a concept that was developed by Fonagy and his team. Parental reflective functioning is an essential aspect of the way parents can understand and signify their infants' behaviors. The capacity to recognize that the infant or the toddler has mental states, feelings, thoughts, and intentions of its own. It is related to the parent's sensitivity to understand that both the child's and their own behavior and emotional displays are connected and in meaningful ways. When relating maternal reflective functioning to dyadic affective regulation, we found that high reflective mothers showed less positive affect, more neutral affect. But at the same time, these mothers and their infants showed a higher rate of positive affect matches, of sharing the positive affect. This could imply that higher reflective mothers can attune affectively with their infants in a more subtle and accurate way. As children grow up, their capacity for affective regulation is transformed and becomes more complex. Adult child play is an ideal scenario to observe affects, symbolization, and the symbolization as an affect regulator. So, in a group of mother-infant play situation with 4 or 5 years old children, we examined, among others, the dyadic mode of interaction, which can be convergent, sharing the same agenda of play, or divergent, where there is a conflict about sharing this agenda, child's level of symbolization during play, and the presence of affective dysregulation signs, both in the mother and the child. There we found that when mothers have low reflective functioning, there are more signs of affective dysregulations in the infant. In addition, signs of affective dysregulation are linked to more divergent interactive mode and lower level of symbolization in the play. These results support an important psychoanalytic idea, the existence of an intimate connection between the mother's disposition to contain and include in her mind affective processes linked to her relationship to her child, and the child's level of affective regulation, which has an impact on child symbolization. As clinicians, this makes us think about the importance also of offering ourselves to parents as a reflective stance to think about their child and their relationships and affects. So, having described a bit of our research, I would like to conclude reflecting on the idea of prevention in early childhood and how it can be connected to research findings and clinical work with babies and their caregivers. To do so, I would like to share the perspective offered by the Brazilian psychoanalyst Regina Ordagao. She reviews the idea of prevention in the work with babies and their caregivers from a psychoanalytic perspective. It is essential, the notion of the uniqueness of each relationship, of each interactive dance rhythm with his matches, mismatches, repair cycles, as I said, and to distinguish the prevention from prediction. A psychoanalyst, whether from his or her position as clinician or as researcher, should distinguish between prevention and prediction. A predictive stance precludes the emergence of the unexpected, which defines our psychoanalytic work, while a preventive stance favors and respects the subjective and individual timing of infant and parent, where mismatches will be repaired in a unique way, and gives place to the emergence of the unexpected. I think that when faced to clinical work with infants and their parents, research findings as well as theoretical knowledge and clinical experience should provide us a frame, a shelter, that this precisely gives us the freedom to place ourselves in a position of reflective listening and subjective involvement to discover the unpredictable and the potential each parent-child relationship has for the change. So, thank you very much, and I apologize for my bad English, but I hope you understood something of this.
Thank you, Constanza, very much for your expanding the field of psychoanalysis through building bridges between psychoanalytic conceptualizations and research-based studies. Well, we have arrived now to the second part of our webinar. We have received many questions. I remind you once more that you can go on sending your questions by the question box. And I'd like to begin with this following question. Just a second. Are you working with consultations online with parents and baby? Did you have new consultations in these pandemic times? Do you want me to read it again? Did you receive it? It's okay?
Yes.
Well, it's an open question to the four of you. Who wants to begin?
I can.
Yes, of course.
Yes. I don't know for you, but the answer is yes. It's quite an exercise to work on the screen with a mother and a baby. It's much easier when it's a toddler, or let's say starting 9, 10, 12 months old, because then we can really connect with a child that we don't know by being very present and using our face and reacting to the child. Like you said, Constanza, the moment the child is being connected, and to allow the child also to relax and perhaps to integrate its own experience and to come back. But what is very difficult in our time right now is how to help and to provide support for people that we cannot meet, and then not to have the bodily experience and to use our imagination to figure out, you know, the sensorial experience in a mother and a baby is quite a challenge. And I think this kind of deprivation could be a kind of metaphor, representation of what the families are experiencing, which is a lack of support, lack of containment, lack of pleasure. That is so destructive. Perhaps it's too harsh to say that, but it's making them at risk. That's why I said that we will be facing depression not only in adults, not like we are now, but in children. You know, there is a deprivation of that sharing that you described, Constanza. So as much as I can say. I will adjust that with young children that can be playful, which is very young children, but then they are active. It's amazing how it's efficient and how they ask you to come back to the screen. But when they are younger, when they're in the first year of life, it's really about the maternal neediness and positive transference, and very demanding also in terms of what the psychoanalyst can do.
Thank you. Want you to add any comment, Daria, Regine?
I want to add something. what Christine was saying, because I see the same in my private practice. But you know, we know that, for example, here in New York, and I'm sure in many places, we talk about the tale of two cities. And the work with the patients or in the private practice is different than the work with patients that are part of a community center and clinics. So I have my private practice, and I would totally agree with Christine. That's what I see too. In the community center, where I'm still in touch with 4 mothers, it's a different story. And their level of chaos and disorganization and how overwhelmed they are makes it very hard to connect with them. I think they feel, I think there is a certain embarrassment, a certain shame to show. Some of that, we stay in touch a lot through texts, and we'll talk, but I think that also they really cannot even organize the time to be able to speak. So that is hard. That worries me much more, and I think that we will see the repercussions to that later on.
Mm-hmm.
I add what is not exactly a question, but a requirement, a suggestion, is an attendee that asked if I wonder if we will have a chance to have distance education about working with babies and their parents. Distance education.
Yes.
Well, it seems that distance education came here and it will last and it will remain with us, even if we hope this necessity will end. And I think it's one of the very, very little advantages of the situation. So I hope that sometime or another that will arrive.
Well, I pass to the next question. It's addressed to Constanza. It says, please give examples of preventive and versus predictive stances.
Well, I mean that both we have results in research and when we have our theoretical background and ideas in our clinical field, and also when you try to establish a program of intervention, for example, it is a problem, the temptation to try to see what will work on, what will not. I mean that kind of prediction. Sometimes as clinicians, we have no flexibility to see the possibilities. We know about trauma, we know about all the risk factors or situations, and it is more difficult to see all the protective capacities each person has as a community, as a subject in the clinical work. So I think the risk is to predict problems where you can find solutions, or solutions where then you can have problems. I fear of the idea of shutting to the difference that can arrive, that are unexpected. I don't know if I mean with that, if I answer.
Thank you. So we pass on to the next question. I am a consultant at the neonatal, sorry, I send it to you. I am consultant at the neonatal intensive care unit where parents cannot be with their infants due to the concern about pandemic. The care team offers FaceTime opportunity to parents to observe and hear their mostly premature babies. Welcome thoughts of helping parents emotionally connect with their babies while physically separate. Mothers are encouraged to pump breast milk and bring it daily to the unit. Who wants to begin? Regine, please.
Maybe just a word. Babies need milk. It's clear. They need the milk of the mother. It's clear. But they need all which is linked with the mother, the voice of the mother. The separation is, we know that being a premature baby is something very difficult because it's all the universe known in the pregnancy, in the intrauterine life, disappears. And each time something disappears, it's a disease. So we need, as all the teams working around, need to decrease the new aspects, the unknown and new aspect. So maybe in this situation, the voice is something that can be transmitted to the newborn alone by the new ways of communication, all which will help this baby to make the link between the old elements known in the old world known before birth. I think that all this will be a factor of prevention.
Can I add something?
Christine, of course.
Yeah,
yes.
because when you were talking about the voice, I was thinking also about the smell. So that could be more difficult perhaps to provide the child with a smell, since you don't want to,
It's terrible.
Stuff could make it more difficult, but nurses are so good, at providing babies in intensive care, providing babies with presence and emotional sensorial presence. Nurses with a premature baby are very good. They know very well how to do that. And I was also thinking, giving the parents feedback about their baby. Your baby likes very much to turn his head like that, to be touched on the feet, because usually premature babies have a too sensitive skin that they cannot be touched, and so on. So, to give the parents some representation about the babies. Of course, they can sit, they can have a video, or I guess they can really exchange. At least we have some technology for that. But to have this back and forth between the parents, creating representation of the body sensation of the baby, and the baby being given some stimulus about the maternal presence.
Okay. Yes, Dalia, please.
With the smell, I was reminded of the infant research that was done in the 90s of giving babies their mothers shirts, T-shirts or nightgowns, whatever they were sleeping with, and which was embedded with the smell. And the babies who had the schmate, the piece of fabric with the mother's smell, ended up being calmer than those that had just any other fabric, which makes me think that a mother might be comforted with the idea, because sometimes you need to feel you can do something, of giving the hospital a piece of her, something that has her smell, to put in the baby's crib as a way to feel that they are connected. Well,
so we pass to the next question that is addressed to Regine. I send it. One of my clients is a mother who described the traumatic experience in her deliveries as the most extreme fear of death during the deliveries. Her coping with existential fear was manifested in severe hypochondriac fears and anxieties. How would you recommend to work with her to be able to shield herself from this trauma that continues to emerge constantly in her life, even when her children are growing and their family life continues? Well, please, first you, Regine.
Yes, well, you can hear me? It's okay? Yes, it's difficult to answer on a question on one's clinical situation that I don't know, but I think that the feeling you talk about in this question about hypochondriac ideas and feelings, that mean that certainly the whole experience of giving birth was taken as a full anxiety moment and a terrible moment. And I think that we can then work with the terror of what could happen, the terror of what could happen in the way we make babies, which is, I worked a lot with a lot of mothers on this. It is incredible. Is it really like this that it works? What we learned in books, it's exactly like this that we make baby. I could not believe it. I think that in this moment is a confrontation with the old sexual infantile theories, and it's the next step of this infantile theory is the real birth, and realizing that it's like this that we make baby, and it's something terrifying. I think that maybe with an hypochondriac aspect, I could add something on this aspect of the feeling, like something completely abnormal and incredible. And then I think that the most important to have a relief is to show the terror, as I said, and in the same moment, what you said with the premature, giving back a view of the baby to the parents. I think it's the same, to focus on looking at the baby. What is the real possibility of the baby to do by himself? I think that the Constanza research, I didn't know this topic, and I was very interested in the difference with the mother in action, in interaction with the baby, and the baby in more neutral. And I think it's like this in real life, that mothers overwhelm the babies with what they want him to do and with their anxieties. And anxiety decrease if we can just look at the baby and describe what is he doing, opening his eyes, looking in this direction, doing this or that. And I think that this is the real good, in my view.
Mm-hmm. Do you want to add something, or we pass? Christine, please.
I was thinking in a much more classical way. Sorry, you will find me very, I would say, conservative. But I was thinking that a woman who had this experience of terror of dying could be, if she is in the kind of association that we can work with her at this level, thinking about the death of whom? The death of the parents, the death of the baby, or the ambiguity, ambivalence towards her own mother, towards the child who was making her suffering so much, towards her husband who penetrated her and making her pregnant, or the doctor who made an IVF, or whoever, was the intrusive intruder in her body. But to work at a very more, I would say, Oedipal, pregenital level, about who is killing whom,
Yes.
and perhaps to take that on more active than passive way. And that made me thinking, because you talked about Julia Kristeva, about the abject, the representation. It's not a representation, the viewing of the birth as a kind of Medusa scene that makes also more of an existential feeling than a capacity for symbolization, and needs to be worked on. So psychoanalysts, I think, are the best for that.
Thank you. Yes, Regine?
One word more, you speak on a Oedipian and neurotic level, and I would add something on a very archaic level. Yes, the fight between death and life during the birth itself, and the two one are fighting, but in a philosophical point of view, and psychoanalysis follows a philosophical question. Who is the murderer? Who is the murderer? The mother who gives life? Okay, when you give life, you give in the same time death. You give life to a human, in the same time, you know, when you make him this gift of being alive, you know that you give the gift of death in the same time. Do you understand what I'm saying? And so
Yes.
I think it's a big crisis also, and I think it's important to face this. Oh, you are terrified with phobia, impulsive phobia. It's something I found very clear in my clinical practice, that if you show to these mothers who lost their self-confidence and they consider themselves as potential murderers, if you show them that, oh yes, you are terrified by your responsibility to give life, and so the reverse is you give life, you could give death also. This is a relief to realize this, that it goes together. It goes in the same time together. Well, I realize that I'm very in a rather clear line working like this, in what is opposite, and that in itself this opposition bears anxiety. Okay, it's being human maybe.
Thank you. Well, so we pass to the next question. Are there any clinical examples of same-gender parents and infants? How would you apply the psychoanalytic framework when there is no physical mother presence or two female presence, but only one of them is the mother? Yes, Talia?
You know, this is always a very rich area of work because I think there is the more concrete or political way of thinking about it, and then there is the more thoughtful psychoanalytic way of thinking about it, because in the child's mind there is always the mothering one, to use Winnicott's words. You know, there is the mothering one, whoever takes care of the child in the ongoing holding way, and there is the more father-like. I've seen it in same-sex couples. It's not so much about the body as it is about who takes that role of the mothering one. So that is very interesting. I think that eventually children are doing with that all kind of things with their fantasy, you know, because children develop fantasy very early on. So a lot of it is very subjective and personal, and will be known, you know, in these children's mind with time when they go to their own therapy. But I think that it's for children, it's about parents and having the mothering one and the third to create a kind of dynamic that they need in order to be able to grow, develop, have a mind.
Mm-hmm.
Can I say something?
Yes, Christine, please.
So I was thinking, of course, this is a population that we see, at least in the US, it's a long time practice, you know, to get babies by different means. But let's talk about adoption. You know, we still see babies that have been adopted. there is always a process of adoption, you know, even if it's your own baby, it's a stranger in the room, like Montalis used to say. So a baby is a familiar and a non-familiar presence. I think there is something, so I don't think there is something very specific in terms of homosexuality, heterosexuality, in the way to be with a baby in terms of fantasy about gender, certainly, but it's not the same in heterosexual couples. What could be different is the medical way to get the baby. If it's a baby that comes from sperm donor, a baby that comes from egg donor, and when we say donor, nobody is donating anything, you know, it's a money exchange. When it's about IVF, when it's about another woman carrying the pregnancy, and then the more you have a distance from the biology and from the bodily experience, the more there is a need for, you know, a good imagination and a good capacity for representation, by the way, to make the baby being part of the bodily experience of the one who is parenting. So yes, in this case, we are in a good position to help those parents, and those babies, sometimes they need help, but the parents, yes, they need help. They need support, you know, to manage their own representation about the baby having a body and a gender when it comes from another planet.
Regine, please.
Yes, I think that the first question with, I have not a lot of experience with these clinical situations that are linked to modern life, but I think that what we work first, what I work at least first, with babies, it's not the question of the difference between a mother and a father and a man and a woman and sexual differences. I think that the main difference is the difference of the territory, the psychic and physical territory of each one in the family. And for instance, in the example you gave, Talia, I thought with this baby playing with the mother, and you said that he just wants to play with his mother, I think that with the idea of what is the territory of this little boy, I should have had the idea of, well, what is impossible to play by yourself? Oh, do you think that you cannot play by yourself? And if you have this question of what is the territory of the responsibility of the baby itself, and what is the territory of one parent and of one another parent, of another person, I think it's a clear organization that helps to build his own identity, which is the most important question, I think, the first. Okay.
Yes. Yes. Well, we have time for a last question. I'm sending it. Do you treat autistic child mother fantasies? In my country, it's predominant the medical line guide that is against this method. Do you have any experience of this topic of literature?
Yes. Yes, I can answer. You know, the answer is yes. A huge amount of literature from Frances Dustin until, I don't know, in France, Geneviève High and you, Regine, or in South America, you know, Monica Cardinal in Buenos Aires, a lot of people. You know, yes, the answer is yes. We can send a bibliography if you want. Yes, of course. Yeah.
But we don't know now, in this special context, are we sure we are allowed to talk about autism and psychoanalysis? if we are allowed to talk about autism and psychoanalysis, of course, we have all the literature you talked about and experiences of prevention of autism or observation of autistic babies in observation at home by psychoanalysts, and a lot of clinical experience in this direction. But it's a real tragedy now. It's so violent socially that we can have the impression that we cannot link autistic problematic and psychoanalytic thinking. Yes.
Well, it's a pity, but we have received many other questions, but our time has run out. You know that this webinar is going to continue online also, that the panelists will be able to receive and answer your pending questions, and you might also send new comments. You have to send it by the website, the IPA website. On the webinar page, you'll find the box entitled comments. There you can send your answers and your questions. Well, we have to leave now. Thank you very much to the panelists, to the attendees, that with your contributions, you have been able to create this open and lively discussion. Thank you very much. I only would like to remind that we'll have next month, on May 10th, it's going to take place our next webinar, and the subject will be on the COVID-19 accident at the heart of human. The COVID-19 accident at the heart of human. Well, we hope you'll join us again, and thank you very much.
Thank you.
Thank you.
Bye.
Okay.